Our goal here, overarchingly, is what we like to call adding life back to years. So we want to restore function to the parts of the urinary tract that have been injured either from trauma or that have been affected from surgeries or treatments for other conditions.
One of the benefits that we have is that we're able to, as a team within MedStar Reconstructive Institute, can really address all of the patient's needs without needing to send medical records outside of the system, without need of potentially an inability to operate at the same institution because we're not privileged at that hospital. So because of that, and because we have multiple large hospitals here in the DC area that we can serve these patients, we offer patients an excellent opportunity to kind of be a quote-unquote one-stop shop. We do certainly the highest volume in kind of the mid-Atlantic region as it pertains to many of the prostate cancer survivorship issues. So artificial urinary sphincters, penile implants, fistula surgery, urethral reconstruction.
We also see quite a few patients who have incontinence after treatment for prostate cancer or for other reasons, including benign conditions like enlarged prostate. We also see a lot of patients with sexual dysfunction, and this might be erectile dysfunction that develops after treatment of a cancer, or it may be something that develops from benign conditions like the side effects or complications of diabetes, hypertension, atherosclerosis, cardiovascular disease, and other neurologic conditions.
At MedStar, I was treated for a recovery of my prostate surgery that did not go well. I arrived at the hospital on an emergency basis because I was bleeding through the anus because of a failed prostate surgery. The outcome was that for 2 years now I've had an ostomy bag. That's to be reversed in a few weeks. And the catheter I fought with for quite some time. I had that removed, I guess, towards late last year. I have an artificial sphincter to control leaking, and I'll have that for the rest of my life. My quality of life for the last 2 years hasn't been real great. I think once I get rid of the ostomy bag, I'll be in a much more normal situation where I can take care of business when I need to, but it's given me time to relax and grow. I started doing a lot more reading than I had hoped for years to be able to do, and I can do that. So MedStar's kept me going. If I hadn't come down here, I don't know where I would be.
When it's been studied, it probably around 3% of all men who are living with incontinence actually end up getting treatment for it. So there's this huge gap of men who are clearly suffering every time they've been studied. You can talk to them in the clinic anecdotally that are suffering, and a very small number of them get treated for it. There are options for you. Now, you might not like the options and you may prefer to live exactly the way you're living now. That makes perfect sense to me if that's the camp that you land in, but you have to know that there are options. And one of those best options is an artificial urinary sphincter.
Erectile dysfunction after treatment for prostate cancer and other pelvic malignancies is quite common, and it can happen commonly with age even without those other conditions. And we have a wide breadth of treatment options that range from least to most invasive. Basically, we would start with pills like sildenafil, tadalafil, other medications that work in the same mechanism. And failing those, we can move on to what's called a vacuum erectile device. And after that, there's also injections available that patients can learn to inject themselves.
Many men who were at one point overweight or through a totally separate disease process than obesity may develop a symptom, or a symptom complex, I should say, called buried penis. Basically what that is skin or fat or both is pushing everything over the head of the penis, sometimes with such severity that men haven't been able to see or expose their penis for months or even years. Typically what we'll do is do some different techniques, including the potential for skin grafting and other very kind of advanced techniques to expose the penis to allow them to return to more normal urinary and sexual function. Fistula is an abnormal connection between two structures. That necessitates not only a skilled urologist in reconstructive surgery, but also frequently a plastic surgeon, as well as a colorectal surgeon working in tandem. That's a complicated 3-surgeon procedure, which often lasts the majority of the day. Transitional urology, or transitional medicine in general, is different from gender-affirming care. Sometimes it does get confused. For young men and women who have complex congenital conditions, frequently they require a multi-specialty care team that has been with them often since birth at a children's hospital, and now they're transitioning in their late teenage years or early 20s to adult care, which is fraught with being fragmented and complicated by insurance, and oftentimes providers will or won't see certain diagnoses. So in conjunction with one of our partners at Children's, who also has a role here in the MedStar Reconstructive Institute, Dr. Erin Teeple, she and I have really begun to formalize and build up a transitional urology program with the goal of better serving these complicated patients as they navigate an already very fractured system, from leaving that organized pediatric practice to coming to adult care. Many patients come to me often with tubes and drains and other things in place, often at a very low point. So this is whether it's from radiation or surgery or whatever the cause is. Some patients who will come to me in that situation are told that they don't have another option, that they're going to have to live with these tubes forever. More often than not, with a team-based approach, we can get patients into a substantially better situation than where they were.